So, good evening, ladies and gentlemen. Good evening, doctors, our PG students, and our consultants. Thank you so much for joining our yet another edition of Impact PG. As you must be aware that we are constantly doing this program on every Saturday between 7 p.m. to 8 p.m. Today, I'm very happy to welcome each and every one of you for the 28th topic, that is case discussion on infective endocarditis. We have Dr. Prem Prakrit with us, who is a consultant in Lizzie Medicity Hospital, Kochi. Thank you very much, sir, for sparing your valuable time and joining today's topic as an examiner. I know it's very so important, this 1 hour for you is, but still in the interest of students, you have taken your time and joining this program. Thank you, sir. I also take this opportunity to welcome Dr. Vamsi Krishna, who is also from Aster Ramesh Hospital, who is pursuing a second year of the DRNB course.
Thank you.
Guntur. So we really look forward for today's case presentation on infective endocarditis, and I'm sure all the students would find this interaction mutually beneficial. As you're all aware, we'll be uploading this YouTube on Monday of post the session. So you can also have access to all our previous versions of this program, which will also help you prepare for the examinations, which is scheduled in the month of September. So with this brief note, I welcome Dr. Prem Prakrit to take over the session from here. Over to you, sir. Dr. Prem? I think his video is frozen. Rahul, can you just check with sir?
Yes, sir. Yes.
Dr. Prem, am I audible? Hello? Sir, we are not able to hear your audio. Maybe some signal fluctuations are there. Can you recheck your audio, sir? Dr. Prem, am I audible?
Sir, I think sir is having some kind of network issues. Sir, better use it.
Thank you, sir.
Yeah, Dr. Vamsi, can you start your presentation in the meanwhile?
Sure, sir. Sure, sir. I'll start, sir.
Dr. Vamsi, yeah, am I audible? We're presenting a case and we'll proceed with the discussion. Yeah. My side, it is fine. Sir, I can hear you. Am I audible now?
Yes, sir. Vamsi, kindly reduce your audio and then continue to present, sir.
Yes, sir. Good evening, sir.
Yes, good evening.
Hello, sir. Good evening, sir.
We can hear you, Vamsi. Please continue.
Yes, sir. Good evening, sir, and thank you for this wonderful opportunity. Sir.
Yes. Good evening. Am I audible now?
Sir, you have some net issues, sir. Dr. Prem, you have some net issues.
Shall I start, sir?
Hello, Prem, sir.
Ask Prem, sir. Sir, you can switch off your video and continue, sir. Yeah, Vamsi, please start. Doctor, we can see the Dr. Prem.
Am I audible now?
Vamsi, I suggest can you present from your mobile phone? We will turn the PowerPoint. I think there is some issue in your audio.
Okay, sir. Sure, sir.
Altaf, do you have the slides?
Yes, sir. We do have the slides.
Please open the slide desk. Dr. Vamsi, kindly join from your mobile phone, sir. Jaya, can you please permit Dr. Vamsi? Shivaram?
Is my screen visible?
Yes, sir.
Yeah, yeah. Your skin is visible now.
Sir.
Good evening, sir.
Yes.
Visible, sir.
Dr. Vamsi, please go ahead, sir. It's over to you.
Yes, sir. Good evening, everyone. Today, thank you for this wonderful opportunity. Today, I'm going to discuss a case about infective endocarditis. And my moderator is Dr. Prem Pratik, sir. A 56-year male patient, a former patient resident of Guntur, Andhra Pradesh. His marital state is married. Came with chief complaints of palpitations in 6 weeks. Palpitations in 6 weeks and shortness of breath since 2 weeks and also fever since 10 days. Patient had altered behavior since 1 day. Next slide, sir. Issue of presenting illness. The patient was apparently asymptomatic
Yes.
until 6 weeks ago when he developed the palpitations of insidious onset. Initially, the episode was intermittent, occurring 3 to 4 times per week, lasting 10 to 15 minutes. It is exertional in nature and were relieved by rest. Over the past 2 to 3 weeks, the palpitations have become more frequent, occurring even at rest and occasionally during sleep, suggesting the progression of the symptom. The palpitations are not associated with any chest pain or syncope or dizziness or post-palpitational diaresis. Next slide, sir.
Yes.
Patient also developed a breathlessness of insidious onset, initially occurring in moderate exertion, that is climbing 3 flights of stairs, and relieved by rest. Over the past week, his symptoms progressed to paroxysmal nocturnal dyspnea, with episodes occurring about 2 hours after sleep, waking up and improving on sitting upright and taking deep breaths. Since the past 4 days, he also developed breathlessness even at rest, which worsens on lying supine, that is orthopnea. It is associated with easy fatigability and limiting her daily activities also. Next slide, sir. The patient they also had a high-grade continuous fever since 10 days, from 10 days, associated with chills and rigors. He was treated at a private clinic, following
Yes.
which the fever subsided temporarily, but recurred the next day despite the medication. During the same period, he also developed progressive worsening of breathlessness, palpitations, and a cough, which prompted her to seek further medical attention. Next question.
Okay.
Patient developed altered behavior since 1 day of acute onset, characterized by confusion, irrelevant speech, and disorientation to time, place, and person. The symptoms have been continuous and progressively worsening. There was no history of seizures, loss of consciousness, or any head injury, or urinary or bowel incontinence, or any alcohol or drug intake. Next slide, sir. Past history. The patient had no similar histories in the past. Patient had a recurrent history of urinary tract infections. Patient is a known case of type 2 diabetes mellitus for the past 15 years and hypertension for the past 9 years and on irregular medication. There is no history of coronary artery disease or any chronic kidney disease or chronic liver disease, bronchial asthma or chronic obstructive pulmonary disorder or tuberculosis or thyroid disorder or malignancy. There is no history of a previous cardiac surgery, prosthetic valves replacement or any pacemaker implantation or intravenous drug abuse or recent dental procedures or any blood transfusions or major surgeries. There is no history of cerebrovascular accident, seizure, or recurrent hospital admissions. Next slide. Treatment history. Patient is a known case of type 2 diabetes mellitus for the past 15 years and was prescribed tablet GMA, that is glimepiride 2 mg and metformin 500 mg. He is also known case of hypertension for the past 9 years and was prescribed tablet telmisartan 40 mg. However, the patient has been non-compliant with both medication and has been not taking a medication regularly since for the past 1 year. There is no history of insulin use, no drug allergies, or no long-term steroid or immunosuppressive therapies. Next slide, sir. Family history, there is no significant or relevant family history.
Yes.
Next slide. Personal history is a patient had a mixed diet and also appetite is decreased for the past 4 weeks onwards. Patient had a disturbed sleep with from the onset of illness due to shortness of breath. Patient bowel habits are regular and bladder habits are normal. Addiction, there is no history of smoking, alcohol consumption, or tobacco chewing or drug abuse. Dental hygiene, patient had a poor dental hygiene, which shows the multiple dental caries are present for the patient. Next slide, sir. General examination. On examination, patient is irritable and disoriented, moderately built and moderately nourished. Patient is febrile with temperature of 101 degrees.
Okay.
Pulse is
So can you go back to the first slide? Shall we discuss the history first?
yes, sir, yes, sir.
Okay. So coming on to the chief complaints. Chief complaints again. Am I audible?
Yes, sir, audible, sir.
Yes.
Sir, audible, sir.
So, okay. So, can you describe the symptoms once again? Chief complaints.
The patient actually had a complaints of palpitations, sir, since 6 weeks. And later patient palpitations of later patient had a shortness of breath from past 2 weeks. Patient had a fever which is insidious in onset
Yes.
since 10 days. And
Okay.
for the last one day, patient had altered behavior, sir, altered sensorium.
Yes. So, can you describe the palpitations?
Palpitation means the unpleasant hearing of one's own heartbeat to their self.
No. How was the palpitation in this patient? You
Yes, sir.
like,
Palpitation is
go on to the history of present illness. You have described the palpitations. No, there. Can you read that?
Can you go to next slide? History of present illness.
Yes. Yes.
Patient,
Yes. Yes.
patient had a insidious onset, sir, in palpitations. Initially, patient felt the palpitations intermittently, like per day. Patient used to feel the palpitation for 3 to 4 times for about 10 to 15 minutes, sir. And on patient, when he is doing on exertion, patient had an increase in the palpitations and relieved by taking rest, sir. But over the past
Okay.
2 weeks, the frequency of the palpitations increased, and also palpitations also occurred during the sleep, and during the rest also palpitations were increased, sir.
So, right.
And palpitation is
So,
not
can you?
associated with yes.
Yeah. So, what do you think is the reason for this palpitation? So, he
Uh,
presented to you with palpitation.
yes, sir.
Okay. So, like, how do you interpret this? What could be the reason for this palpitation? What do you think?
Palpitation. If a patient comes with a palpitation, there can be many causes, sir. Like patient can have anemia, and also patient can have hyperdynamic circulation syndrome diseases like thyroid disease, or patient can have any valvular cardiac abnormalities like any valvular deformities uh, or any acute ischemic infarct like changes.
Mhm. Okay, so in this patient, what could be the reason for this palpitation?
Mostly due to
According to
patient,
history.
because of mitral valve regurgitation, patient can have palpitations, sir.
Okay, so what kind of MR? So he started having palpitation 6 weeks ago, right?
Yes, sir.
Which is a relatively short duration. So
Yes,
for
sir.
a de novo mitral regurgitant lesion of the mitral valve, suppose most commonly we see mitral regurgitation in what? In most likely rheumatic heart disease, okay, where they
Yes, sir.
have chronic MR.
Chronic
They
MR.
usually have present palpitations for years, okay, which will
Yes,
be
sir.
gradually progressing,
Yes,
okay,
sir.
and they tolerate palpitation very well. They may not have any other symptoms. In this patient, he has got a very short duration of palpitation, just started 6 weeks ago, and which progressed rapidly. So, what could be the reason for this? Why do you think that this is MR?
Patient can have acute symptoms in acute infective endocarditis conditions. Not if patient had a subacute, then patient will have symptoms for long duration.
So, like, suppose this patient has presented to you with only palpitation. You don't know whether there is MR, this infective endocarditis or not. So, like, how do you approach this? That's what I'm asking. Palpitation.
Firstly, we'll check
So, you
for
have mentioned, yeah, tell.
First, we check for any cardiac causes. First, we'll check for patient CBC, HB reports to rule out anemia, and later we'll go for
No,
past history.
no, we are now in the history only, So, from history, what all things you will ask? So here you have mentioned that these episodes were intermittent, occurring 3 to 4 times per week,
Yes,
lasting
sir.
10 to 15 minutes. What does that mean?
It denotes that there is a progression in the palpitation episodes. So we have to ask the patient regarding the any previous history of rheumatic heart disease or any rheumatic fever conditions.
Okay, so see, yeah, when if you are suspecting a rheumatic heart disease which is causing MR, unlikely, most likely it is a chronic MR, and patients will have symptoms for years. Most likely they will have palpitations, which they tolerate for years. There may not be any other symptoms. Okay, so you will get his longer duration of his symptoms. If it's palpitation, they may have palpitation since like for last maybe 2 to 3 years. They'll have gradually progressive uh, palpitations. That's how your chronic valvular regurgitant lesions present to you. So this is just 6 weeks. And you mentioned that episodes were intermittent and 3 to 4 times per week, lasting 10 to 15 minutes. So what do you think? What could be the reason? So if I am having a patient presents to me with palpitation, intermittent, some 3 to 4 times per week it is coming, and lasting for 10 to 15 minutes. That's all. So what it could be?
Any AF episode can be.
So yeah, so if there is a like if the episodes are very much intermittent, and 3 to 4 times he's getting a sudden onset and sudden offset of palpitation, most likely it is an arrhythmia. Okay, your history is like something like that. Here, suppose if there is a paroxysmal supraventricular tachycardia, usually presents like this. No? So short duration of history. In between, they have palpitation. Okay, patients will have palpitation, sudden onset of palpitation, and sudden offset. Here, mostly this kind of palpitation happens in arrhythmias. Okay. Be it any arrhythmia, it could be a supraventricular arrhythmia or a ventricular arrhythmia or whatever it may be. But usually they'll have arrhythmogenic palpitations or arrhythmic palpitations are uh, 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 palpitations due to arrhythmia usually presents like this. Okay. Then valvular heart disease. Valvular heart disease, they'll have palpitation which is continuous. All every time they, I mean, it's not related to. They may not have a sudden onset and a sudden offset. Baseline only they'll have palpitation, which may worsen during exertion, but they'll have a baseline palpitation. Even if the patient is resting, they can have palpitation. So regurgitant lesions usually presents with palpitation. They have palpitation because the volume of blood in the LV is more, so the force of contraction of LV will be more. That's why they feel palpitation. They have palpitations. Okay, so there the history will be like gradually progressive palpitation. Maybe a little the severity can increase during exertion, but even during rest they'll have palpitation. Okay, regurgitant lesions will present like that. The episodes are very much intermittent, occurring 3 to 4 times per week, lasting for 10 to 15 minutes. There is something happening in between, like for the 10 to 15 minutes, there was some abnormality which has happened that is causing palpitation. Okay. So this history is more like an arrhythmia. That's what I feel. Suppose if it is a valvular problem, then which valvular problem can present like this? Acute, like very short duration history of palpitation, which is progressing rapidly.
Mostly for the left ventricular, like MR or MIAS, AR, we can see, sir.
MR due to what? So if a patient presents to you with palpitation, there could be three possibilities. One, there could be a possible problem with the heart rate. Second, could be a problem with the rhythm, and third, could be
Force of
something
contraction.
related to the force of contractility. Okay, these three things can cause palpitations. Okay. If it is an arrhythmia causing palpitation, usually it'll be paroxysmal with sudden onset and sudden offset. Okay. They may have post palpitational diuresis with supraventricular tachycardia causing arrhythmia, causing palpitation. If it is if the palpitations are due to increased force of contraction, usually you get in regurgitant lesions like mitral regurgitation or aortic regurgitation. They have longer duration of symptoms. But in a particular group of MR, they can have, or AR, they can have short duration of symptoms. In which group? If it is an acute MR, okay, an acute AR, due to what would be the reason for an acute MR and acute AR? Am I audible?
Yes, sir. It's audible, sir.
So acute, can you tell me if you
Hello, sir.
infective endocarditis is one of the causes. Okay. And you can have that in papillary muscle dysfunction and it's associated with an MI or something like that. So when you have an acute MR, they can have palpitations of a shorter duration. And patient may decompensate very fast. Unlikely to be a chronic MR. In chronic MR, they tolerate palpitation for years. Okay. Suppose if it's a traumatic MR, they'll have symptoms of palpitation, which will be gradually progressing since many years. Okay. But if the patient presents with acute onset of palpitation, very short duration, rapidly progressing, then you should think of, if you are thinking of valvular heart disease, you should think of acute MR and acute AR. Other possibilities are like what you have told, an anemia. 6 weeks history of palpitation could be an anemia. other causes like hyperthyroidism or arrhythmias. All these things are my first possibilities rather than a chronic rheumatic heart disease causing a chronic valvular regurgitation. Okay.
Yes, sir.
Understood. So this we have to keep in mind. Acute MR causing palpitation, they'll have a rapid progression. Very, they'll progress rapidly to heart failure. They may have or may not have fever, and so this acute infective endocarditis, subacute infective endocarditis is one of the cause. Okay, fine.
Yes.
So yeah, next slide, please. So here you have written that after since last 2 to 3 weeks,
Yes, sir.
palpitations are continuous. Okay, even during rest, he's having palpitation. Okay, which suggests that it's unlikely to be due to an arrhythmia. Okay, so every like continuously the patient is having symptoms of palpitation, so which suggests that could be a it may not be an arrhythmia, or if suppose arrhythmia is persisting, it's continuous arrhythmias now, or
Any structural abnormality can be.
yeah, any structural abnormality, usually a regurgitant lesion, or other common causes like anemia, thyrotoxicosis, everything you have to consider. And if patient presenting present if the patient presents like this, short duration 6 weeks history of palpitation, much common things are there. No? Like anemia is one of the common cause. Okay, and even thyrotoxicosis, physiologically they can have pregnancy, they can have, so all these are possibilities where the patient can present to you with short duration history of palpitations. Understood. So straight away going to infective endocarditis with this history is a little like you can't comment. I mean, directly you can't tell that this is an infective endocarditis in the exam. Okay, you have to think of other possibilities, other common differential diagnosis first, and then you can include one of infective endocarditis as one of your differential diagnosis, maybe lower down in the list. Okay. Okay. Then proceed, please.
Yes, sir. Patient developed breathlessness.
Hmm.
Patient developed breathlessness of insidious onset, initially occurring with a moderate exertion, that is climbing three flights of stairs, and relieved by rest. Over the past week, his symptoms were progressed to paroxysmal nocturnal dyspnea, with episodes of occurring about 2 hours after sleep and waking him up, and improving on sitting upright and taking deep breaths. Since the past 4 days, he has developed breathlessness even on the rest, which worsens on lying, that is orthopnea. It is associated with easy fatigability and limiting his daily activity.
So what is it? What does this suggest? So this patient has developed breathlessness. Okay, initially started with palpitations, now started having breathing difficulty. So which has progressed, right? Progressed over last 2 weeks. So how do you interpret this?
Patient is a breathlessness, sir, due to decrease in the either it can be due to either pulmonary cause or cardiac cause, sir. In pulmonary cause, we can take it. Patient can have any pulmonary edema changes or any pneumonia like that, sir. And patient till now there is no fever history, though we can rule out pneumonia, sir. And in cardiac causes, patient due to arrhythmia, also patient can have a shortness of breath, sir, or any acute infarct condition, any MI condition also patient can have shortness of breath, sir, and any fluid overload conditions.
So how
Due
do you
to left
differentiate
ventricular failure.
breathlessness due to respiratory cause and cardiac cause?
On exertion, there is an increase in the breathlessness, sir, which denotes mostly of a cardiac cause. If it is pulmonary cause, then it can be the continuous breathlessness will be.
Okay, so usually your breathlessness due to a cardiac cause of breathlessness. Usually it starts with breathlessness, and later they may have progressive breathlessness. They'll have cough later, but in respiratory they usually begins with cough. Okay, cough, expectoration, and breathlessness usually will be the next symptom. Okay, if it starts with cough and then breathlessness, most likely it is respiratory. If it starts with breathlessness and then cough, most likely it is cardiac, but there can be overlap. Okay, then what else? How will be the sputum in respiratory breathlessness and cardiac cause?
In respiratory, it will be like a pink frothy, sir. Sputum will be pink color.
In respiratory.
Yes, sir.
So in cardiac cause, if it's a
Data flow rasta penthouse మనకు data flow వచ్చి
because they'll be having pulmonary edema, right?
penthouse మనకు data flow వచ్చి hello
Hello, sir.
Hello.
Yes, sir.
yes sir please go on because someone is unmuted.
Okay, so they cardiac breathlessness usually will have breathing so cough with frothy sputum, while in respiratory cause of breathlessness they'll have cough with mucoid or mucopurulent sputum. Okay, then associated symptoms. Suppose the patient has got, see here, the patient has presented to you initially with palpitations, which is rapidly progressing. So you know that there could be an underlying cardiac condition. Okay, so associated symptoms like palpitation, chest pain, syncope suggests that this breathlessness could be a cardiac, could be due to a cardiac etiology. Respiratory, usually, if it is secondary to an infection, they'll have fever, okay, cough with purulent expectoration or mucopurulent expectoration. So associated symptoms, based on that also we can differentiate. Okay, suppose there is a history of seasonal variation of breathlessness. Okay, seasonal exacerbations, history of nebulizations. So all these point towards a respiratory cause of breathlessness. And if there is a history of family history of breathlessness, or childhood history of wheeze, or history of atopy, all these favors respiratory cause of breathlessness, bronchial asthma, and conditions like that, you can have a all these history of atopy, history of skin allergy or food allergy, childhood history of wheeze, history of previous nebulization. So all these point towards a respiratory cause of breathlessness. Breathlessness responding to nebulizations so suggests respiratory cause. Breathlessness responding to points towards a cardiac cause of breathlessness. So that's how you differentiate cause of breathlessness. So here you have a patient with breathlessness which is progressed over last 2 weeks. He is having PND and orthopnea. So PND is very much specific for a left heart dysfunction, left heart failure. So which is very much specific for left heart. So if there is a history of PND, that suggests that this breathlessness could be due to a cardiac etiology. Okay, so this breathlessness, according to the history, I think that this is most likely a cardiac cause of breathlessness. Okay, so what is the mechanism of PND?
During patient during sleeping patient, there will be decrease in the venous return, sir.
Sorry.
During sleeping, there will be a decrease in the venous return for the patient, sir.
Decrease in venous return.
Yes.
Usually, when you are supine, so your venous return should increase, no?
Yes, sir, it should increase, sir.
Any mechanisms that you are aware of? PND. So So PND is the same. Like when you lie down, okay, your peripheral, say the fluid which is accumulated there in your interstitium, it redistributes. Okay, and the fluid which is there in the interstitium enters the what? Your vessels. It redistributes itself to the intravascular compartment. So amount of blood reaching back to the heart will be more. So if it's a failing heart, this heart will not be able to tolerate the extra amount of blood that is reaching the heart. Okay, when you are supine, so that can precipitate what? That can increase the left ventricular and diastolic pressures. That can go and cause pulmonary edema. Okay, it's one of the mechanisms. There are many other mechanisms. You can go back and read. So mechanisms of PND. So PND is which class N by HA? If you want to grade PND as a symptom according to NYHA, PND comes
Is
to which class of NYHA?
grade 4, sir. 4th grade, sir.
So grade 4 is breathlessness even during rest.
Rest.
Is it not? So PND, it comes with class 3. Okay. Understood? Class 3 NYHA. Okay.
Yes. Okay, sir.
Class 4 is breathlessness even during rest. Okay.
Even during rest, sir.
Understood.
Yes.
So yeah, so this patient has gotten. So what do you think this is now? According to this history, till now, patient has developed breathing difficulty. I mean, palpitation initially. You think that this is the palpitation is because of an acute valvular regurgitation, or other possible DDs like common things, anemia, serotoxic, all those things. But since it has progressed so fast over last 2-3 weeks, you are thinking in terms of an acute valvular regurgitation lesions. Okay, that is one thing, or arrhythmias, whatever it may be. Now this patient has developed breathlessness. So what is it?
Yes, sir.
How do you correlate this?
Patient also had breathlessness with palpitation with breathlessness, sir, which they tells more about the cardiac cause. And if a patient has a breathlessness with a paroxysmal nocturnal dyspnea, then patient will have most likely have a left ventricular failure, sir. Patient is
Okay.
landing into left ventricular failure, sir, dysfunction. So
Yes.
patient can mostly have the disorders of left ventricular side, that more of any abnormalities like valvular abnormalities.
Okay, fine. So you're more into a cardiac problem, okay, presenting initially as palpitations, and now presenting with and progressing to have rapidly progressive breathing difficulty. So your symptoms have progressed from, that why I say class 2 to class 4 within maybe maybe over 1 to 2 weeks. So which is uh, which is uh, which is unlikely in a chronic valvular regurgitant lesion, or it should be complicated by something else, either an infective endocarditis or an arrhythmia. Okay, so that's our different. These are our differential diagnosis. At least till now, if you can analyze the history according to your history, these are the possible differential diagnosis. Okay, so moving on to the next slide. Can you just move on to the next slide, please? Yeah. So can you describe the symptom?
So patient had a continuous high-grade fevers for 10 days, sir, from 10 days,
Yes.
which is associated with the chills and rigors. He also treated in the private clinic, for which the patient's fever has been subsided temporarily, but again recovered on the next day. During the same period, patient developed a progressive worsening of breathlessness and palpitations, which prompted him to seek the further medical attention.
Okay. So what about this symptom? What do you want to correlate?
Fever. Patient had a fever episode, sir, which may likely indicate the patient can occur due to any tropical causes or any infective etiology, with patient with fever and SOB and with palpitations, which denotes a cardiac cause, then it can be of myocarditis or infective endocarditis can be suspected, sir. And patient to
Yeah.
rule out the infection, we have to send the tropicals for the patient.
Okay. So at this point of time, the patient has developed palpitations, which is progressed over last 6 weeks, which is almost like rapidly progressive. And again, he had what breathing difficulty, so we are suspecting a heart failure also. So palpitations plus symptoms of heart failure with fever. Okay, so what are your possibilities? So tropical infections. Okay, but the thing is, the symptoms have started since last 6 weeks. Okay, and it started with palpitations. Okay, and then heart failure symptoms, then fever. So tropical infections usually don't present like that. Starts usually with fever, then maybe progresses to involve organs. Okay, they can develop uh, heart failure due to myocarditis later. Okay, here the patient had heart failure symptoms first, then fever. So maybe you can tell infective endocarditis as one of your first degrees after this. Then maybe you can tell about other infections. Okay, understood?
Yes.
Okay, so uh, can your fever complicate your cardiac functions? Can it worsen the cardiac function? So patient had
Sir,
palpitations. Suppose patient had palpitation and heart failure symptoms. So having fever, just fever itself can worsen your cardiac functions. Okay,
fever
understood.
itself increases the
This may
heart
not
rate, sir.
be so that itself can decompensate the heart and can precipitate heart failure. May not be an infective endocarditis person. Fever due to any cause. Okay. Suppose he develops a pneumonia, or he develops a UTA or something like that. That itself can worsen the cardiac functions and can have a similar percentage. So these are the differential diagnosis that you should keep in mind when you have such a case. Okay, so you have a underlying cardiac disease which is progressing. Okay, he is an elderly person, no,
It's 56 years.
56 years. So this initial palpitations, it could be because of an ischemic heart disease. Okay, ischemic heart disease causing a papillary muscle dysfunction, acute coronary syndrome. He's a diabetic also. He may not have a chest pain. He can have papillary muscle dysfunction, which can cause an acute MR, which can progress rapidly. Okay, that can present to you with palpitations. Understood. And they can have heart failure symptoms. Okay, so all these are possibilities. Understood. They can have an infection anytime that would have worsened the symptoms. So all these are the broader aspects. All these things you have to keep in mind when you analyze such a history. Okay, just by telling that the patient has got rapid, early progressive palpitation and heart failure, you can directly tell that the patient is having an infective endocarditis. All other possibilities you have to consider and you have to keep in mind while you tell for the exam. Okay, when you tell the
Yes,
differential diagnosis.
yes, sir.
Understood? Okay.
Yes, sir.
So what could be the reason for this fever? Is it because of anything else? Because of something else?
Sir, can you tell one, sir? Actually, your audio has been.
So this fever, what could be the reason for this fever? Other than infective endocarditis? You've mentioned about all other things. Your tropical illnesses, pyelonephritis, pneumonia, all those things you told. But you have to keep in mind that this patient can develop infections anywhere because of the systemic septic embolization. Okay, they can have septic emboli to the heart, to the brain, to the kidneys, to the spleen, to the liver. So they can develop an abscess anywhere if it's an infective endocarditis. So if a patient has got rapidly progressive heart failure symptoms and developing fever secondarily, you can definitely think of infective endocarditis. You can mention that as one of the important DDs, and complicated by fever could be because of infective endocarditis per se, or could be because of the complications due to infective
Cases of the
endocarditis.
infective
Like,
endocarditis.
yeah, okay, fine. Okay, next slide.
Patient developed altered behavior since 1 day, sir, of which is of acute onset. It is characterized by confusion, irrelevant speech, and disorientation to time, place, and person. The symptoms have been continuous and progressively worsening. There was no history of
Yes.
seizures or a loss of consciousness or a head injury or urinary or bowel incontinence or alcohol or drug intake, sir.
Yes. Okay. So, what could be the reason for this behavior?
Patient can have meningitis, which are meningitis, sir, acute meningitis,
Yes.
or any brain abscess like due to septic brain abscess condition. Since patient has a fever and
Yes.
altered behavior, there can be acute meningitis or brain abscess or any acute infarct in ischemic condition, sir.
Yes. Yes. Can they have bleed, hemorrhage?
Yes, sir. Subarachnoid hemorrhage is also possible, sir, because it presents with both altered behavior and fever also occurs in subarachnoid hemorrhage, sir. But
No. Can
mostly unlikely,
infective
sir.
endocarditis, can it cause bleed? Can
Sir?
it present with bleed?
Yes, sir. Actually, infective endocarditis itself can cause a aneurysm, mycotic aneurysm like condition, sir. So it
Yeah, so
can
it could
cause
be
a
a bleed
subarachnoid
also.
hemorrhage.
Yeah, it could be
Yes.
mycotic aneurysm rupture causing an IC bleed. Could be an ischemic infarct because of a septic emboli. There can be abscesses. Okay, so all these are possibilities for meningoencephalitis. So all these are possibilities for the altered behavior. Other metabolic problems can also be their electrolyte abnormalities or febrile delirium, or all these are the other possibilities. But when you correlate everything as per your previous history, so this is one of the like complication of an infective endocarditis. Okay,
Yes, sir.
fine. Proceed, please.
Next slide, sir.
Yes.
Patient had no similar history in the past, sir. Patient had a recurrent history of urinary tract infection, sir. Patient is a known case of diabetes mellitus type 2 since past 15 years and also hypertension for the past 9 years, who is on irregular medication. He has no history of coronary artery disease or chronic kidney disease or any chronic liver disease or bronchial asthma or
Fine,
chronic obstructive pulmonary disorder or tuberculosis or thyroid
nothing.
disorder.
Uh, any okay, fine. Anything positive from your past? Positive family history. I mean, past history. If
Sir?
there is anything, you can mention. Otherwise, you can move
No,
on.
sir. There is no relevant family history in the past, sir.
Proceed, please. Oh, okay.
Next slide,
Okay,
please.
fine.
Treatment history. Patient is a
Yes.
known case of type 2 diabetes
So
mellitus
he was
from the
he's a non-diabetic, hypertensive, non-compliant.
yes, sir. Not
Okay,
taking
fine.
any medication, sir, and also and the sugar levels are also high, sir, when the time of admission during the time of admission, which shows he's a uncontrolled diabetic patient.
Okay, fine.
Next slide, sir. There is no
Okay.
significant family history,
Proceed.
sir. And
Yes.
next slide. Personal history, patient diet is mixed diet and the
Yes.
patient has decreased in the appetites for the past 6 weeks and there is disturbance in the sleep due to from the onset of illness. Patient has a bowel habits of regular and bladder habits of normal. There is no history of smoking, alcohol consumption or tobacco chewing. Patient has a poor dental hygiene. Patient has multiple dental caries or
Why
presence.
is drug abuse important?
Sir, why is?
Why have you asked for history of drug abuse?
Patient who have consumed the alcohol can also have presented with the symptoms of palpitation, sir. And also IV drug abusers are most likely to develop any disorders related to Infective endocarditis is most likely to cause in IV drug abusers, sir.
Okay. So IV drug abuse is one of the risk factors that can lead to a right-sided infective endocarditis.
Infective
Okay. So
endocarditis.
that is one. Yeah. Okay. Fine. Poor oral hygiene. How, how is that relevant?
Actually, normally
Poor
oral flora is not normal oral flora is good for a patient, sir. But a patient who's having uncontrolled diabetic sugar and with poor hygiene, patient may develop oral infections, which may lead to infective endocarditis, sir, through by
Okay.
entering into systemic circulation.
Okay. Proceed.
Next, let's. General examination on arrival, patient is of irritable and disoriented, is moderately built and moderately nourished. Patient is febrile with 101 degrees temperature. Patient has a pulse rate of 132 per minute, which is irregular of normal volume. His blood pressure is 100 by 70 mmHg, and respiratory rate is 36 per minute. And his saturation is 84% on room air. So we have kept the patient on O2 support with 10 liters. On 10 liters, patient has a saturation of 94%, and patient is a paler. There is no icterus, cyanosis, clubbing, or lymphadenopathy. Pedal edema is absent, and JVP is not elevated.
So can you just describe like why is he tachycardic? That could be the reason for tachycardia.
Patient. One reason could be patient is febrile, sir. It could be one of the cause for the tachycardia, sir. And another reason could be due to insufficiency in the
Yes.
left ventricular outflow. To compensate, patient can have tachycardia, sir. Or any sepsis patient,
Okay.
even in sepsis condition also tachycardia occurs, sir.
And you've mentioned that the pulse is irregularly irregular. No, so there's some arrhythmia which is going on. You don't know whether that
Yes,
is causing the tachycardia. Okay,
yes,
is
sir.
it not? So which
Yes, sir.
arrhythmia can have an irregularly irregular pulse?
Atrial fibrillation, sir.
Okay, other causes.
Any ventricular ectopics can also have irregular pulse.
Yes. So if your pulse is irregularly irregular, what are you supposed to check? You're supposed to check the pulse deficit. Okay. Okay. Anyway, can the volume be normal if the patient is having irregularly irregular tachycardia?
Not usually, sir. Not
So you have
usually
to
a
mention
normal.
that it is variable.
Yes, sir, variable.
So it will be a variable volume because the pulse is irregularly irregular. No? So each pulse will have a variable volume.
Variable
Okay.
volume.
Not normal. Understood. No? So okay, fine. So he's tachypneic also, right?
Yes, sir.
36 per minute. 36 per minute. Okay, fine. Okay. What could be the reason for tachypnea in him?
Due to due to heart failure, patient can have tachypnea, sir. To
Okay. Reasons for
accommodate the
tachypnea, heart failure, then yes.
to compensate the oxygen to compensate the metabolic needs, patient starts to take up any metabolic acidosis.
So tachypnea basically because of heart failure and pulmonary
Heart
edema,
failure.
is it not? That is one thing.
Yes.
Other causes?
Metabolic acidosis can cause tachypnea, sir.
Yes. Okay. Then
Metabolic,
in
which
him.
is metabolic acidosis, which is most of course sepsis induced, can cause
Yes. Okay.
tachypnea, sir.
Then
Uh, any respiratory causes like pneumonia can also cause a tachypnea, sir.
in this patient, if we are suspecting infective endocarditis and the patient is tachypneic, one thing is heart failure. Second,
Yes.
okay, sepsis
Pulmonary edema, pulmonary
related
edema also. Sepsis
acidosis or
related, sir, and pulmonary
something
edema,
like
sir.
that. Then that's basically because of your IV failure now.
Yes,
Yes.
sir.
Even fever itself can cause tachypnea. Is it not? And if patient is having a infective endocarditis, they can have a septic pulmonary emboli. is it not? Septic emboli to the lung, which can cause pneumonia in the lung. So that it's or lung abscess or whatever it may be. That can cause tachypnea. So all these are the possible reasons for tachypnea. Is it not? Okay. Then
Saturations of 84% on roommates.
what is the reason for pallor? Okay. Why is he having pallor? Pallor could be because of shock. We don't know. Is it not? So you just mentioned the blood pressure, but we don't know whether the patient is having clinical signs of hypoperfusion. So you're supposed to mention that also. Is it not? So if the patient is having a clinical signs of hypoperfusion, they can have pallor. Or patient can have anemia. Is it not? In infective endocarditis, they can have anemia because of an ongoing hemolysis. Okay.
Restriction in the RBC in the spleen can cause.
Yeah. Yes. So anemia is one of the finding that you get in infective endocarditis that can cause pallor. They can have even icterus also. They can have clubbing also. So all these are all these things you have to look for. Okay, the icterus because of an ongoing hemolysis, or if there is an associated liver problem, like if there is a biventricular dysfunction, congestive hepatopathy that can cause icterus, or if there is a hepatic abscess that can cause icterus. Okay, all these can cause icterus, or even hemolysis can cause icterus. Okay, in infective endocarditis. Okay, clubbing, rapidly progressive clubbing or new onset rapid onset clubbing or painful clubbing can be seen in infective endocarditis. So all these things you have to you have to see. Understood. Pedal edema is absent. Okay, JVP is not elevated. Okay, fine. Okay.
Next slide. Systemic
Yes.
examination, CVS examination, inspection, precordium appears normal. There is no visible precordial bulge or pulsations. Apex impulse may be visible in the fifth left intercostal space, lateral to the mid-clavicular line. There is no chest scars.
Yes.
Next slide.
So comment on the. Can you comment on the inspection finding?
There is no any precordial. Precordium appears normal, sir. There is no previous history of any CABG, any surgeries by the visible, sir. And patient.
Where do you see precordial bulge?
In the left sternal border, sir.
Okay, so that is not a precordial bulge. Precordial bulge is something which is just actually a skeletal abnormality that you get in usually in congenital heart diseases. Okay, so you are supposed to tell that there are no visible pulsations. That's all. Okay, precordial bulge is it's something which has to do with the skeletal framework. Okay, so that you get typically in patients with congenital heart diseases. Okay, not in adults. So no visible pulsations you can tell. Understand? Apical impulse in the fifth left intercostal space, lateral to the midclavicular line. Is that normal?
Slightly deviated, sir, from the. Actually, it appears in the fifth intercostal space in the midclavicular line, sir. But it is slightly lateral to the midclavicular line.
So why is it shifted laterally?
Maybe because of left ventricular hypertrophy, maybe increase in the left ventricular volume, sir.
Okay, maybe we can see it later. We'll keep that in mind. Okay, proceed, please.
Next slide, sir.
Yeah.
Palpation, apex beat displaced to the sixth intercostal space anterior to the axillary line. Apex beat is hyperdynamic and thrusting. There is no parasternal heave or left parasternal. No, there is no parasternal heave. There is no palpable thrill, sir.
Next okay, slide. So now you tell me, why is it shifted to the left intercostal space? Just to sixth intercostal space. So that's a significant shift, no?
Mostly because
It
of
is
the left
shifted out
ventricular
and down,
failure.
is it not? It is shifted out and down. It is shifted
Out and
towards the anterior axillary line and towards the sixth intercostal space. So, what could be the reason?
Mostly because of the left ventricular failure. There is no decrease in the pumping from the left, decrease in the left ventricular outflow, sir, leading to accumulation of volume blood in the left ventricle.
Okay.
That can lead to
So, the
left
thing
ventricular
is, this left
hypertrophy.
ventricular failure there only since last 2 weeks. That's the problem. Within 2 weeks, you don't expect your LV to dilate so much. Okay. So if there is an apical impulse shift from which is shifted out and down, you expect a volume overload situation in the LV. Usually, you get in regurgitant lesions, and mostly this is because of a chronic valvular regurgitant lesion. In chronic MR, we expect a finding like this. Okay, so in this case, you have to retrospectively go and ask if long-lasting palpitations, which is progressing since many years. Okay, because you expect such a finding not in an acute MR. In acute MR, your LV is usually not dilated. Okay, understood. So if your LV is dilated and that has caused apical impulse shift to the left and down, then it's something chronic. Okay, and now an infective endocarditis would have complicated. So that is why the symptoms has symptoms of and hyperdynamic apex beat. Okay, fine. Where do you get hyperdynamic apex? Since you have mentioned all this, that's why I'm asking all this. Okay, where do you get hyperdynamic apex?
If a patient is in shock, then we can have hyperdynamic apex, sir, or any anemia condition. Patient is in if a patient is in
Okay, so you
cardiogenic
get
shock, we can
hyperdynamic
have.
apex. So in usually you get hyperdynamic apex in a volume overload of LV. Okay. How do you can you define hyperdynamic impulse, apical impulse? Okay, you can go back and read. Okay, how do you define hyperdynamic impulse? How do you define what are the abnormalities of apex? Are you aware of that? It's more likely a medicine question, but since you have mentioned that the apex beat is hyperdynamic, how do you identify hyperdynamic apex?
There will be
Okay, fine. Proceed. You
there
can
will
go
be
back and read.
heave
Okay.
or a thrill can be seen, sir. Parasternal heave can be seen, sir, for a hyperdynamic.
No, both
Apex
are
beat.
entirely different. Hyperdynamic apex is entirely different. Parasternal heave is entirely different. Okay, you can go back and read. Okay, done.
Yes, sir.
Proceed, please.
Next slide. Auscultation
Yes.
S1, S2 normal. Murmurs patient has a pansystolic best heard murmur at the apex, which is radiating to the left axilla, sir.
Okay, so what do you think that it is?
Mostly, if the patient has the apex murmur in the apex region, it can be mostly of mitral regurgitation, sir, due to mitral valve close, sir.
Okay.
If it
Okay.
is your pansystolic, it occurs during continuous systole phases, the more it indicates towards the MR, sir, mitral regurgitation.
So, see, according to your history and examination, see, history is only short, is it not? Short duration of palpitation and worsening heart failure symptoms. But when you examine, you're seeing that the apex is shifted out and down, and you've got a pansystolic murmur at the apex, radiating to left axilla. If it's a acute MR due to infective endocarditis, you may not get a pansystolic murmur. Okay, because your LA is not compliant. Okay, and the MR, the mitral regurgitation jet will stop soon after it begins. Okay, so usually you get a short systolic murmur if it's an acute MR. Understood. If you have got a pan systolic murmur, which is extending all throughout the systole, then you know that the LA is compliant, and you have a regurgitant jet, which is starting from the onset of systole, ending till and going on throughout the systole and ending till the onset of diastole. So, which means that this is a chronic MR. This is not the murmur of an acute MR. Okay, and moreover, you can you based on your examination, your LV is dilated, LV apex is shifted out and down. So most likely, this patient is having a chronic MR, and the acute worsening could be because of an infective endocarditis, which has happened now. Understood.
Yes, sir.
Okay, so you have to retrospectively go back and ask for the history of a chronic mitral regurgitation, which is there. Understood? Or something, some other valvular valvular history, such as any other chronic valvular diseases. Okay, and this short history since last 6 weeks is because of a complication which could be an infective endocarditis. Okay, most likely this patient is having a rheumatic heart disease with a chronic mitral regurgitation. Now, this patient would have developed an infective endocarditis. That's what I'm like thinking as per your history and examination. Okay, okay, proceed please.
Yes, sir. Systemic CNS examination. Patient is irritable and restless. Patient is
So where are you
confused. It is
supposed to focus findings?
sir, your voice is breaking, sir.
Will you usually your focus lung focus and your echo findings and all you're supposed to mention along with the system examination, right? Or you'll be mentioning that separately?
I mentioned separately, sir, actually.
Okay, fine. Okay. So if you in critical care, actually you can integrate all those with your system examination. Suppose if you're telling if you're telling a respiratory system examination, after clinical examination, you can incorporate your ABG, you can incorporate your ventilator settings, all those things, so that you can finish off all those in along with your respiratory system. And
Thank you.
coming on to CVS, you can mention after the clinical examination, you can include your ECG, echo, everything, so that everything else is this is more like a medicine case presentation. Okay, that's what I feel. It's up to you. Okay, system examination.
CNS examination, sir. Patient is irritable and restless. Patient is confused, not oriented to time and place. Patient has a irrelevant talk. Patient is moving all four limbs. His GCS is E4, V6, and M6. Pupils are bilateral 2 mm reactive to light, sir.
Okay, fine. Proceed.
Next step. Respiratory system. Patient has a bilateral equal entry with the bilateral basal and inspiratory crepitations are present. There is no V's or no rhonchi. Abdominal examination. Abdomen is soft, non-tender, no organomegaly or bowel sounds are normal, sir.
Okay. Yes. Proceed,
Next
please.
slide, sir.
Yes.
As per up to
So
this
what else
patient,
you have to tell in your examination? What you have missed? What have you missed in the examination part? So according to your history, you were suspecting infective endocarditis, right? So when
yes,
you
sir.
examine the patient, you have to look for the stigmata of infective endocarditis. Is it not?
Yes, sir.
So you have not mentioned that anywhere in your examination. You should be looking for what? What all things you look for in your examination?
Look for any osseous nodes or nodules, any
Yes.
pitake, JNY lesions,
Yes. So you have to look for all
or
those
any
things.
rock spots.
Yes, yes. So you have to look for all those the stigmata of infective endocarditis. Usually, you get the stigmata of infective endocarditis in a subacute infective endocarditis, not in an acute infective endocarditis. Your acute infective endocarditis usually presents with heart failure. While your subacute endocarditis can have all these findings. You have to carefully look for all these road spots in the fundus, gene lesions, Osler's nodes, all those things. Okay. Hmm? Because you have got a clinical criteria, no, to diagnose infective endocarditis. So all these things
Yes.
you have to examine uh, when you do a when you get a case. Okay. Okay. Proceed, please.
As per the history, patient differential diagnosis, patient can have acute heart failure, sir, which can be by cause of valvular abnormalities or by arrhythmias. Patient is having fever and altered confusion which can denote to patient can have any acute meningitis or metabolic encephalopathy, encephalopathy due to a dyselectrolytemia or uremia. Patient can also have pneumonia or sepsis or any tropical fever, sir.
So, okay, so we have mentioned, we have discussed in detail about the differential diagnosis. Okay, we'll move forward
Next slide, sir.
because of time constraints. Okay,
Yes. Next slide.
yes.
Investigations we ordered on the first are ABG, sir, and ECG, and a complete blood picture was done. Renal function test, liver function test, and cardiac panel.
So can you
and
just
bronchial
describe
panel.
like what all abnormals do you expect in
Yes.
ABG
Yes, sir.
and each one
Next
of
slide,
this?
sir. Yes, a patient
Yes.
in EBG patient is of sepsis, sir, so he can have a metabolic acidosis with respiratory alkalosis can be present, sir. Compensation. In
Metabolic
ECG
acidosis
patient
due to what?
due to infection, sir. Sepsis induced metabolic acidosis, sir.
How sepsis causes metabolic acidosis?
The lactates will be increased, sir.
Most likely it's a lactic acidosis, is it not?
Lactic
Okay.
acidosis.
Other possibilities in sepsis? Other cause of one is lactates because of hypoperfusion. Then systemic hypoperfusion related lactic acidosis. Then suppose this patient is having a heart failure also. No, it could be a cardiogenic
Heart failure.
component also to the hypoperfusion that can cause lactation, not purely sepsis. Okay. Then they can have a kidney injury. Is it not?
Kidney impairment can also
Yeah,
cause
so
due
that can
to the
contribute. Yes.
decrease in the clearance of the H plus ions.
Okay, kidney injury, they can have high anion gap metabolic acidosis. This patient is a diabetic, so they can have a diabetic ketoacidosis, which is contributing to the high anion gap metabolic acidosis. So all these things you have to keep in mind when you have such a case, is it not? Hmm? So what was the ABG finding of this patient? Are you mentioning that?
Yes, next slide.
Okay, okay. Just move on. Okay.
Next slide, sir.
Hmm.
ABG findings, sir. Patient has a pH of 7.31, sir, and PCO2 of 26 mmHg, sir, and the bicarbonate is 16 millimole per liter, sir. Lactates are 3.8 for this patient, sir, on oxygen support of 10 liters per minute, sir.
So how do you approach this ABG?
Actually, this denotes the patient had a severe lactic acidosis, sir, mainly.
Yes. So how do you approach an ABG with metabolic acidosis? So what? First of all, what acid-base disorder is this?
Metabolic acidosis, sir, with respiratory compensation.
Okay. Then
Actually, partial compensation of respiratory, sir, not completely compensated.
okay. So what is the expected by PCO2? Have you calculated? So can you quickly describe an approach to a metabolic acidosis in ABG? Just mention that's all. In general, suppose the patient is having metabolic
Treatment part,
acidosis.
sir. In treatment part, sir, or
No, in general, can you mention approach to metabolic acidosis? Suppose ABG is having metabolic acidosis, how do you approach that?
first, if a patient has a metabolic acidosis, we'll check for a respiratory. If there is patient has a respiratory compensation or not, sir.
Yes. So then, what are the next step that you want to? You're supposed to do the
Anion gap, sir. Next, we'll check for anion gap, sir.
PCO2, no, to know the compensation, to know whether that's an associated
Respiratory compensation or not, we'll check for PCO2 levels, sir.
acid-base disorder. So you should know the compensation. Yeah.
Yes. Next, we'll check for anion gap,
Yes.
sir, in
Then
metabolic acidosis.
after that, yes. Then
After checking the anion
you
gap,
can
we'll pressure.
calculate you can check the corrected anion gap. because most of these patients will have hypoalbuminemia. You can check for a corrected anion gap, and then even you can see for the delta ratio, right? Delta
Delta
ratio.
ratio, sir.
Is it not? Okay,
Yes, sir.
fine. So that's in short how you approach. So I'm not going into details. So ECG, you have mentioned that there is sinus tachycardia, but your pulse was irregularly irregular, so it doesn't correlate. So maybe you can, I don't know, was it actually sinus tachycardia or something else?
Actually, when we took the ECG, patient had sinus tachycardia, sir. But during examination,
Okay, fine. Okay, then focus.
next focus is done, sir. Patient has a good LV
Focus.
function. Focus is done, sir, which showed the patient has a good LV function, sir. IVC is collapsing. There is no pericardial pleural effusions. As of now, we had no vegetations are not seen, sir, in the focus. Because of tachycardia,
So
patient,
see, according to your examination, you were having findings suggestive of an dilated LV, is it not? Shifted apical shift was there. It was like hyperdynamic effects. But your focus echo is showing a good LV function. So how can you explain that? You had symptoms of heart
actually
failure.
it is
Okay.
very
Patient had
inconclusive
PND,
study, sir.
orthopnea.
Due to sinus tachycardia, the focus is also very inconclusive, sir, during the study.
Okay, fine. But LV function was good. That's what you're telling. LV systolic functions were good.
Actually, by eyeballing technique, we saw, sir. In that, we assumed like the LV function was fail. That's it.
Have you checked for diastolic dysfunction?
No, sir.
So, see, according to the history, your patient had rapidly progressive heart failure symptoms, okay? And he even had NYHA class 4 breathlessness, PND, then class 4 NYHA breathlessness. And in even your clinical examination also was showing all like a dilated LV, shifted LV, dynamic apex. But when you come to your focus, it's like everything is normal, so it doesn't correlate. Maybe you have to do your like when you have clinical suspicion of infective endocarditis and when you have so much of findings and according to history also and also examination findings were like this. So you have to do your echo little more carefully. Okay, that's what I want to tell. So suppose if your LV function is normal, systolic function is normal, and the patient is having heart failure symptoms, the LV and diastolic pressures, is it not? So that's a diastolic heart failure which is causing the symptoms. Okay, in sepsis you can
Yes.
have a diastolic heart failure also. Okay, fine, proceed.
Next. See, next chest X-ray shows the cardiomegaly, sir. Perihilar opacities were consistent with the pulmonary.
He had anemia also, right?
Yes,
SP
sir.
was 7.8 and thrombocytopenia was also there. I mean, platelets were
Yes, leukocytosis
low
is there,
normal.
sir, and
Is it not?
thrombocytopenia is present, sir, to the patient. Tropicals were
So
negative,
there
sir.
is like almost like a bicytopenia like picture. So that is also again one of the findings that you can have in infective endocarditis.
In fact,
Okay. Yes.
chest X-ray was done, sir, which showed the cardiomegaly and perihilar opacity, sir, which is consistent with the pulmonary edema. Since the patient has a altered sensorium with non-contrast CT brain was done, sir, which showed multiple lignified hypodense areas involved in the left frontoparietal cortex and right cerebellar hemisphere, consistent with acute embolic infarcts. There is no evidence of intracranial hemorrhage or midline shift, sir. 2D echo was done, sir.
Okay.
Patient is non-cooperative due to severe tachycardia, and patient is non-cooperative and due to severe tachycardia, suboptimal study, sir, which showed the severe MR and mild pH. There is no RWMS, sir. Good LV and RV function, sir.
Okay,
USG
fine.
abdomen was done, sir, which showed the grade 1
What
fatigue.
about vegetations?
Actually, patient severe tachycardia and patient is very irritable, sir. So vegetations were not seen that time. So we done the next day we done the repeated the 2-day echo.
Okay.
Next slide, sir.
Okay. Fine. So which is better? Your
Day one course,
TG is
sir.
better or
Patient is
TEE is better?
persistently altered sensorium. Hypertension developed. So patient was started on vasopressor. Patient was not able to maintain a saturation with 10 liters of O2. Tachypnea is persisting, needing the non-invasive support, sir. Lumbar puncture and CSF analysis were done, sir. CT chest was also done for tachypnea, sir. Next slide, please.
What was the lung ultrasound finding when you did?
Sir,
You
lumbar
didn't
puncture, yes,
mention
sir.
anything about the lung ultrasound findings.
Yes, sir. Actually, lung
Your
ultrasound
focus
patient had
includes lung
a
ultrasound.
B line, sir. Patient had several B lines, sir.
Okay. How was the B lines? Was it suggestive of pulmonary edema or was it an inflammatory B line? Was it
Mostly B line
spreads
suggestion
with
of
B or
mostly those B lines suggestive of pulmonary edema itself, sir. They are very vertical, sir.
can you describe B lines in pulmonary edema? How it will be?
Patient will have a continuous hyperechogenic lines, vertical lines, and absence of A lines will be there, sir. In any inflammatory or a consolidation condition, in pulmonary edema condition, there will be continuous vertical lines, sir. But in any
What is it
infection,
called? So you get confluent B lines, is it not? Confluent
yes, sir.
homogeneous B lines. Okay, confluent homogeneous B lines. Then what else? Usually the pleura will be smooth. Okay, smooth. Okay, normal smooth pleura with confluent homogeneous B lines. Is it not?
Homogeneous B line.
Predominantly dorsobasal. Yeah. So and even anteriorly also you can get anterior up also you can. So usually your B lines will be smooth, confluent, homogeneous, and smooth pleura. You can have a bilateral effusions also. It's a pure heart failure B lines. Okay, pulmonary edema B lines. So was it like that?
Yes, sir.
Okay. Then so he
Next
was
slide, sir.
hypoxic also. Then
Yes, sir.
requiring 10
Hypoxic
liters.
also, sir. So requiring non-invasive ventilator support, sir.
So
NIV
why did you
support.
consider NIV in this patient?
Since patient is also have a pulmonary edema, if we resolve the pulmonary edema, then patient can develop the to see if there will be decrease in the tachypnea, NIV support was kept, sir.
Okay. So is there any indication for intubation in this patient at this point of time?
At this point, the patient GCS is fine, sir. More of patient is irritable, but GCS wise patient is around 12 to 13, sir. So intubation was not considered, and hypoxia is there, sir. But with NIV support, is maintaining the saturation, sir.
Okay. So, but what was the PF ratios here? He's requiring 10 liters of oxygen.
Yes, sir.
And his respiratory rate was 3640, extremely tachypneic, requiring 10 liters of oxygen. That means his oxygen requirement is quite high, right? And he has got a borderline GCS. So, would you want to intubate or you still want to give an NIV trial?
Actually, we given a trial for NIV, sir, but next day patient we intubated the patient because of persisting hypoxia and tachypnea, and also patient conditions all deteriorate, sir, because of increase in the vasopressor.
Okay, and especially he's in shock also, is it not? So, all these like point towards like a requirement of an invasive mechanical ventilation rather than NIV. So you can give NIV, but even if you are giving NIV, it should be a careful under close monitoring. Maybe you can give a short trial of NIV, but maybe like I would prefer an elective invasive mechanical ventilation in this patient. Is it not? So, because he's progressively worsening, persistently altered sensorium, new shock, oxygen requirement is quite high. He has got symptoms of, he has got evidence of tissue hypoperfusion. Oxygen requirement is very high. Tachypnea is persisting. So maybe like you can avoid NIV if you want. Okay, maybe I'd keep a low threshold for intubation. That's what I want to tell. Even if you're giving NIV under close monitoring, you can give a trial and keep a low threshold for intubation. Okay, proceed please.
Next slide. CSF report was done. The CSF report findings were normal with a normal lipid, sir. There is no bacterial or tuberculosis or fungal or viral meningitis. And CT chest was done, sir, which showed the bilateral symmetrical diffuse ground glass opacities with the interlobar septal thickening
Yes.
with the perihalar predominance, which is mostly suggesting of a pulmonary edema, sir. Next slide.
Sorry. Okay, so what is the CSF findings suggest you of?
Actually, CSF pressure and opening pressure was around 9 centimeters H2O, sir. Showing no
Yes.
no rise in ICP, sir. And patient
Oh.
color is also normal, sir.
Mm.
And cells were only 4
Okay.
cells, sir. Mostly of lymphocytes, sir.
Okay,
And
so
patient
no evidence.
no evidence of
Okay.
any bacterial or fungal infections.
Sure. Unlikely to be meningitis. Okay, then.
Yes, sir.
What else? CTO suggests you of pulmonary edema.
CT chest mostly shows the perihilar opacities and dome glass opacities and interlobar septal thickening, sir.
Okay, fine. But your echo was normal. That's what you're telling. Oh, he had MR. Okay, fine.
MR,
Okay.
severe MR.
Okay, fine. Good.
On day one, repeat ABG on day one show the metabolic acidity with elevated lactate, sir. Due to severe respiratory distress on NIV, non-invasive ventilator with progressive worsening of septic shock, patient is intubated and placed on controlled mechanical ventilation. Patient developed erythematous macula lesions over the both palms. Review 2D echo, 2D echocardiography revealed mitral regurgitation with a small mobile echogenic lesion on the posterior mitral leaflet, sir, suggestive of vegetations. So empirical antibiotic of injection meropenem 2 gram IVTAD and vancomycin 1 gram IVTAD was started.
So this was a transthoracic echo which showed vegetation.
Yes, sir, transthoracic.
Is it wrong?
Yes, sir,
Okay.
transthoracic, sir.
So which is better for to diagnose infective endocarditis, to detect a vegetation? TTE or
Transesophageal
TE?
echo is transesophageal echo, sir.
Okay, fine. Transesophageal. Okay, fine. So what is the sensitivity? Do you know the sensitivity of TE and TE in diagnosing?
Yes, sir. In transthoracic echo, the sensitivity is 80%, sir. But for transesophageal echo, it is 90%, sir. More than 90% sensitivity, sir.
Okay, fine. Okay, fine.
Yes. Next slide, sir.
So what in which all aspects your TT obviously for sensitivity okay is better. Any other advantages of doing a TEE than TT
We can see the lesions
in
in
relation to
transesophageal echo. We can see the
infective
vegetation, sir, and its size can also be denoted, can be measured. Hello, sir. Hello.
Sir, your voice is not audible, sir. Prem, sir.
We can hear Dr. Vamsi, I think. Prem sir's audio is not. Dr. Prem, can you hear us?
Any
Dr. Vamsi?
other
Yes, sir. I'm here, sir.
One second. Rahul, can you just call Dr. Prem?
Yeah, sir. Calling.
Hello.
Yes, sir.
Okay. Okay.
We can hear Dr. Prem.
Hello.
Yes, sir.
Yes. Yes.
Sir, I'm audible, sir.
Yeah. You are audible, please.
Yes, sir.
So, yeah, you consider transesophageal echo the more than transthoracic echo in a few situations where if you want to diagnose a perivalvular complication like a, perivalvular abscess
Dehiscence
or
of prostatic.
valve dehiscence. So, especially in prostatic valve endocarditis, you would always prefer transesophageal echo. And if you are suspecting infective endocarditis and your vegetations are very small, so that can be a small vegetations can be picked up better with transesophageal echo. And if the vegetations are associated with the cardiac implantable electronic device, okay, associated infective endocarditis, you would prefer a transesophageal echo. Understood.
Yes, sir.
So you recommend a transesophageal echo if your TT is negative or if it is inconclusive and if your
Conclusive.
I is high, or if the TT is positive and you want to rule out a local complication, then also you do a transesophageal echo. Understood.
Yes, sir.
So, where else you do a transesophageal or transthoracic echo? So, if the patient is having inconclusive examination or an initially negative TT or TE and your clinical suspicion of IE is very high, then you can repeat a TT or TE in another 5 to 7 days. Okay.
7 days.
So, for your you have a clinical suspicion of TTE, infective endocarditis, and you have done a TTE or and TE, both are negative, then you repeat that in another 5 to 7 days at least to roll out a possibility of infective endocarditis. Understood. Okay. What are the other imaging modalities available?
Sir, actually, the other imaging modality, sir, cardiac MRI can be done, sir. And to rule out any abscess or meningitis, which a CT brain was done, sir. CT brain can be done, sir. And
Yes.
18 FTG PET scan can also be done, sir.
Yes. So you can do a
For the
cardiac
metabolic
CT or an
activity.
FTG PET, yeah, to diagnose a paravalvular leak and to confirm the diagnosis of IE. So for that, you can do other imaging modalities. Okay. Fine.
Yes, sir.
Proceed, please.
Yes. On day 2, before slide, sir. Patient on day 2, patient is on
Yes.
mechanical ventilator, sir. Patient is irritable, fever spikes were present. Lactic acidosis is still persistent. Urine cultures, CT cultures, and CSF cultures came as negative. Inotic and there is a for blood cultures they have given the flags, but cultures were still not yet come. Inotrope pigment is still persistent. On day 2, patient had a HB of 7.8 and TLC of 26,800. It is increasing in 10, and the patient has a creatinine of 1.8 and the platelets of 1.2 lakhs per milliliter. Next slide, please.
Okay. So you didn't mention about the severity of hypoxia. How was it post intubation? How was lung? How much was the driving pressures? Like how much was the pulmonary pressures? How much PP was requiring? Uh, PF ratios. How was it? So all those aspects you didn't mention. Maybe because you were the patient was significantly hypoxic prior to intubation, right? So and you had a
Yes, sir.
diffuse B lines everywhere. So like how did make intubation help? So all those things you have to maybe you have to mention along with this. And you have not mentioned anything about the hemodynamics after intubation after starting inotropes. Like what is the shock? How have you characterized the shock? What is the reason for shock? Is it pure septic? Is it septic plus cardiogenic? Is it septic plus hypovolemic? What it is? So that also you are supposed to mention along with this. So why is he requiring inotropes still? Is it purely infective? I mean, purely septic, or is there any hypovolemic or cardiogenic component? So all these things you are supposed to mention when you're like presenting a case of infective endocarditis. This is not because patient has got heart failure also, patient has got sepsis also, patient is hypoxic. So it probably is a mixed shock. So ideally you're supposed to mention all these. Okay, how is the perfusion markers? Are the is your lactates coming down? How is your capillary refill? How is your peripheries? Does it require further augmentation of cardiac output? Is there any signs of low cardiac output? So what is the SCVO2? What is the AVCO2 gap? So when you resuscitate a patient with this, especially when you don't have an invasive cardiac output monitor, you can very well resuscitate with an ultrasound when if you have an echo, is it not? So you are supposed to mention all this. It's not. You have to characterize the shock. You have to measure the preload. You have to measure the stroke volume. Is it not? You can use ABG. You can use SCVO2 or AVCO2 gap. You whether to augment the cardiac output further. Should we add a vasopressor? Sure, whether you should go up on the vasopressor or come down on the vasopressor, whether you should add an inotrope, whether you should optimize oxygen delivery further with something else. So all these things you have to include when you present a case of shock. Okay, especially
Yes.
when it's a multi-system case. Understood? Okay,
Okay. Yes, sir.
proceed. Okay, fine.
We have the culture sensitivity report, sir, for the patient, which showed the growth of
Yes.
methicillin sensitive Staphylococcus aureus in all three sets of blood cultures, sir. It is of a gram-positive coccus, sir. It shows a sensitivity for oxacillin and cephazolin, cloxacillin, ampicillin, and vancomycin, sir. It is only resistant to erythromycin, sir.
Yes.
Next slide, please.
So it is methicillin sensitive staph. Okay, fine.
Yes.
Okay.
Blood culture shown the methicillin sensitive staph aureus, sir. Antibiotic de-escalation was done based on sensitivity to injection cloxacillin of 12 grams per day and divided in 4 doses, sir. On day 3,
Okay.
patient is on mechanical ventilator, is of less irritable. Patient inotropes were gradually tapering off. Metabolic acidosis is slowly resolving. Fever spikes also decreased. Investigation showed the decrease trend in the TLC counts and the CRP levels, sir. Next slide, please.
Okay. Fine. So
Patient is
what do you think about this thing about the antibiotic therapy? Any comments
sir,
on
actually,
antibiotic therapy?
patient antibiotic determines based on the oxacillin and methicillin sensitive or resistant, sir.
So is this a common organism
Yes,
which
sir. Staph aureus
cause?
is the most common organism, sir.
Okay.
Except in community acquired, remaining all cases, it is the most common, sir. In community acquired, Staphylococcus viridans is the most common, sir. Streptococcus viridans is the most common.
Staph aureus is also one of the common organisms that cause community-acquired and native and valve endocarditis, is it not?
Yes,
So
sir.
Staphylococcus aureus is also one of the most common organism that can cause
Yes, sir.
community-acquired native valve endocarditis. So what are the? Can you just describe the common organisms? In acute native valve endocarditis and subacute native valve endocarditis, which are the common organisms?
In acute, most common are Staph aureus, sir, and also beta hemolytic streptococci and
Okay.
enterococci, sir. And in subacute causes, the subacute infective endocarditis, there are streptococci viridans, sir.
Yes.
And also in gram-negative causes, there is heck
And
group, sir.
enterococci. Usually enterococci you see subacute. Okay, not acute. Okay, fine. And
In gram-negative, we have heck group, sir, which is Haemophilus and Aggregatobacter and Cordinobacterium hominis and Eikenella bacterium and also Kinganella kinga bacterium, sir. And also some aerobic gram-negative bacteria can also cause infective endocarditis, sir. Mostly of acute causes, they are E. coli or Pseudomonas or Klebsiella can cause, sir.
okay, fine. So usually gram-negative bacteria usually you see in prostatic valve endocarditis, that too in early prostatic valve endocarditis, the GNBs. Most common is cons, this coagulase
Cons.
negative staph, then Staph aureus and GNB and enterococci in that order. Okay, these are the common organisms. Your late prostatic valve endocarditis, it's after 12 months of surgery, again Staph and Streptococcus, same as community acquired. Understood.
Yes,
Where in your patient the organism was methicillin sensitive Staph aureus. No? So what about the antibiotic therapy? Why have you chosen cloxacillin?
sir, for oxacillin sensitive patient, penicillin is a penicillin group of drugs are the most commonly used, sir.
Yes.
In which oxacillin is highly best for the infective endocarditis, sir.
Okay, so
Oxacillin
how
or
much is the dose?
ampicillin can also 12 grams per day, sir. It can be divided into 4 to 6 doses, sir.
Okay. So, which are the alternatives if suppose this patient is allergic to penicillins?
If
What
a
else you
patient
can
has
use?
any allergic to penicillin, then we can go for vancomycin, sir, which is 30 mg
Vancomycin?
per kg over 24 hours. It can be divided into 2 doses, sir, or 3 doses, sir, vancomycin.
Okay, okay. Or you can use cefazolin also as an alternative to oxacillin or flucloxacillin. This is for
Cefazolin,
native valve
cefepime.
MSSA,
Yes,
native
sir.
valve. What about
Yes, sir.
prostatic valve endocarditis caused by an MSSA?
If a patient has a prostatic valve infective endocarditis, then we have to go for a rifampicin, sir, or vancomycin. In rifampicin, it is 900 to 1200 mg divided over 24 hours, sir, in 3 to 4 doses.
Okay, so if the patient is having prostatic valve endocarditis and MSSA, you need not choose vancomycin. You can still treat with oxacillin or flucloxacillin, but you have to add rifampicin, okay,
Rifampicin.
and gentamicin. Okay,
Yes,
that's
sir.
what is recommended. How rifampicin helps? How rifampicin help?
It destroys the cell walls, sir.
Okay, why do you want to add rifampicin?
Mainly, actually, in prostatic valve, they forms a biofilm like
Yeah,
pictures. So,
yes,
in
yes,
order to penetrate, a rifampicin should be given, sir.
yes, yes,
Cell
yes.
penetration most.
Yes, yes, yes. So to prevent a recurrence, you need rifampicin. Basically, if there is any film formation and all, rifampicin is necessary. Okay. So if it is MRSA, if it is MRSA,
If it is MRSA, we have to go for vancomycin, sir.
yes. If it's
Or
a native valve endocarditis, it should be vancomycin. If it is prostatic valve, vancomycin
then
with rifampicin and
vancomycin with
gentamicin. Okay.
gentamicin.
Okay. So when do you tell that it is MRSA? What is the oxacillin MIC for MRSA?
4 mics per ml, sir.
Yes, yes. So if the MIC is more than 4 mics per ml, then it is called MRSA. Okay. So that is about your Staph aureus infective endocarditis. Okay.
Sure.
So where can you find culture negative endocarditis? What are the causes of culture negative endocarditis?
In culture negative endocarditis, we can see in fungal groups, sir, or like a candida, or we can also
Yeah.
see in mycoplasma, sir. Also, Coxella burnetii or Brucella,
Yes.
And
Okay. So I'm not going into details of each organ treatment, antibiotic therapy for each organ. So we can go back and read that. Okay. So can you proceed? Like next slide.
next slide. Next line. On day
Yes.
4, patient is conscious and obeying, sir. Patient is off inotropes. Intermittent fever spikes were present. Since the patient is stable now, we plan for a TE, sir. Since the previous MR showed only very vegetation and small vegetation, so we proceeded for a transesophageal echo, sir. We showed the myxomat as a posterior mitral leaflet with a small 6 into 4 mobile echogenic mass attached to the atrial aspect of the P2 segment of
Yes.
the posterior mitral leaflet. Vegetation with the posterior mitral leaflet with the severe mitral regurgitation, sir.
Okay.
Since antibiotic is given for 3 days, after third day of antibiotic, we repeated the culture, sir. Ideally, after 48 to 72 hours, we repeat the culture, sir.
Okay. So when do you want to repeat? So cultures. How do you monitor antibiotic therapy?
Yes, sir. After culture report, we started on day 2, sir. So after 48 to 72 hours, we repeat the culture, sir, again.
Yeah. So it should be repeated daily. Ideally, it should be repeated daily until they are sterile. Okay. In patients with Staph aureus endocarditis and
Yes,
in difficult to treat endocarditis. Understood. So in this
yes, sir.
patient, you should have repeated it daily. Okay.
Day.
And it should be done again if fever returns. Huh? And again after 4 to 6 weeks to document cure. Understood.
Yes, sir.
Okay, so that's when you repeat blood cultures. Okay, and if fever persists more than 7 days despite optimal antibiotic therapy, or if the patient deteriorates clinically, then you have
We
to
have to go
evaluate
for
for the
surgical options.
complications. Like, yeah, you have to evaluate for splenic renal abscess or paravalvular abscess or for embolic events and all, and at the same time you have to consider surgery. Okay, understood.
Yes,
So
sir.
what are the indications for surgery?
Uh, if a patient had persistent symptoms even after day 7, we have to check for any indication for
Yes.
surgery, sir. That is severe MR or a severe heart failure. Then if a patient has a vegetations of more than 10 with more than 2 episodes of embolic events, then we have to go for surgery, sir. If a
Hmm.
patient has a vegetation of more than 25 in the mitral valve, we should go for surgery, sir.
Okay. So, like basically, if the patient has got heart failure, okay,
Yes, sir.
or if there is any complication like heart block or annular abscess or aortic
Yes, sir.
abscess, or if there is any persistent bacteremia, understood, without
Yes,
any
sir.
other focus, okay, despite on appropriate antibiotics, suppose there is persistent bacteremia and no other focus, then you have to consider, or there's any recurrent embolic events, okay, or persistent or enlarging vegetations despite appropriate therapy, or if there is any severe valvular regurgitation, and if the vegetations are large, okay, as you've mentioned, some 20 or 10
Yes, sir.
so you have to consider surgery.
Yes,
Understood. Okay.
sir.
So surgery, especially in prosthetic valve endocarditis, in Staph aureus endocarditis, very notorious organism. You have, if there is any Staph aureus endocarditis with intracardiac complications or relapse after optimal antibiotic therapy, you have to strongly consider. Okay, if it's a prosthetic valve endocarditis, and if it's a native endocarditis, if it's a very large vegetation, more than 20, if it's a right-sided lesion, and if it's a left-sided lesion, it's more than 30. Or if there's all these persistent fever for more than 7 to 10 days, or relapsing or poorly responsive endocarditis. So all these conditions you have to consider surgery. Understood.
Yes, sir. Next slide.
So, like, what about anticoagulant therapy and antiplatelet therapy in infective endocarditis?
So actually, we have to start, if the patient has embolic events, we have to start the anticoagulant, sir, based on a CHATSWA score. CHATSWA score. If a patient has any recurrent embolic events in any splenic infarct or any renal infarct, then we
Suppose
have to
this, if
start
the
the
patient has got an embolic stroke, ischemic stroke, do you want to anticoagulate? or do you want to give antiplatelets?
Yes, sir. We can start, sir.
So if it's a septic, because this is a septic emboli, that's at a very high risk of bleed. So it's
Yes, sir. On day 5, patient is on mechanical ventilator, sir. Hello.
Yeah, I can hear you, Vamsi. Dr. Vamsi, I can hear you. I think Prem sir is Dr. Prems. Can we hear you, sir? Sir, can you hear us? Dr. Prem?
yes. Am I audible?
Yeah.
Yes, sir. Audible, sir.
Am I audible? Yeah. So anticoagulations, if at all, if you want to consider, you can consider in patients with DVT, with ongoing DVT, or patients with AF, with MS, that is valvular AF, or if in non-valvular AF, if your chart score is more than 2, or if the patient has got a mechanical prosthetic valve, then you can consider anticoagulation if if there is no evidence of a large stroke, large embolic stroke, or an IC bleed, or mycotic aneurysm. If all these things are not there, you can consider anticoagulation. Understood?
Yes, sir.
Okay.
Okay, sir.
Okay. Can you proceed?
Yes, sir. On day, yes, sir. On day 5, patient is on mechanical ventilator, sir. Patient is conscious, obeying commands, sir. No fever spikes were seen since the last 12 hours. So patient has
Yes.
tolerated for extubation, sir. So patient was
Yes.
extubated. So repeat blood cultures came as negative, sir. Patient is well maintained on minimal oxygen support, sir. Next slide.
Okay. Yes.
On day 5, patient sensors improve, sir. Vitals are stable. Patient is maintaining oxygen support. Investigation so decrease in the TLC count. No fever spikes, sir. ABG is normal, sir. ABG is holding, sir. Next slide, please. Patient is hemodynamically
Okay.
stable, sir. No spikes in the past 24 hours. Fever spikes in past 24 hours. Culture was also negative. Routine
Yes.
investigations were within normal limits. After successful stabilization and improvement in a clinical status, patient was shifted out of the ICU in a hemodynamically stable condition. On again day 12th, repeated transeries of transthoracic echo was done, sir, which showed that there is a decrease in the severe to moderate MR. So surgical option was excluded for the patient. Currently, patient was stable, sir.
Okay. Fine.
Next slide, please. Yes, that's
Can
all.
you tell a few echo mimics of vegetation? Echo mimics. Echo mimics of vegetation.
Normal first for any vegetation, first we'll roll out the Liebman sac, sir, and rheumatic.
Yes.
In a rheumatic fever also we have, sir, and non-bacterial thrombotic endocarditis is also we
Yes.
have, sir.
Mm.
Sometimes myxoma lesions of
Yes.
myxomas can also appear as vegetation, sir. Sometimes calcified valves can also appear as a vegetation.
Okay, Raghu. We'll take
Yes.
let's boost.
Hello.
Sir,
Yes.
So
Yes.
continue, sir. Continue.
Yes.
uh,
Yes. Any other causes? Any other like mimics? Any other
that's one.
mimics? Hello.
That's yes, sir. That's what I know, sir.
So other causes are like Lambert excrescences. Okay. There can be a suture ends which are free. Then
Okay, sir. Nice.
false tendons in the LV. So flyer leaflets. All these are fine. So where do you get false negative? in early phase of illness. If you're doing an echo early, you may get, or if it's a vegetations are small, or if there's a recent loss by embolization. If the patient is already embolized, then you can have, or if there is an acoustic shadowing from prosthetic valve. Okay. So these are the causes of false negative echo in infective endocarditis. Okay. Okay, fine. So that's all. Anything else you want to ask?
Yes, sir, that's all.
Okay. Then thank you so much.
Thank you, sir. Thank you so much, sir.
You can stop the PowerPoint, sir. So, thank you, Dr. Prem Prakrit, for joining today's session, sir. I think it has been a little longer session, kind of marathon, from almost 7:15 to 9 o'clock. So thank you very much. Despite your busy schedule, you can join and help us run this program. I also take this opportunity to thank Dr. Vamsi for his patient answering of all the queries from the doctors. So I think for Dr. Vamsi also, it must have been a good experience of learning from Dr. Prakrit. So we also would request you to continue to attend future programs in your own interest. So thank you all the students for sparing your time. I see a lot of senior consultants today, Dr. Samir Sahu, Dr. Anil Satyadas, a lot of senior doctors, I could see them joining. So I take this opportunity to thank all the doctors, including the students who could spare some time to join us today in our Impact PG session. So before we wind up, we would like to also inform you, make an announcement that September 1, 2, and 3, we have an Impact PG physical session happening at Kottayam. There is a flyer which our team would be running or passing through. Please make a note that this will be purely physical session, and as per the course director's instruction, Dr. Jacob George, will be running this program. And I heard a lot of students requesting us to conduct online, but actually the whole objective of this program to have a physical interactions so that a lot of doubts and clarifications can be done immediately. So that's the whole intent. So I hope you will appreciate our intention and would request all of you to join. Please make a note that this time the students will be we'll be enrolling them on a first come basis. So we request all of you to enroll at the earliest. For any doubts, clarification, there's a number in the flyer, or most of you must be there, part of the Impact PG group. Kindly seek the clarification, or you can get in touch with me or our representatives, Mr. Rahul, or other senior leaders from the respective states. So we look forward to meet you. Please make a note that the stay and the food part has been taken care by iNews as a special support for the students, and the rest of the things is purely a academic program. So I request all of you to join and take maximum benefit out of this program. So with this, once again, thank all the students as well as faculties for joining, and a special thanks to all the iNews team members for supporting and coordinating for the students' participation. With this note, I thank you once again, all of you. Have a great weekend. Thank you very much. Thank you, MC, Dr. MC. Thank you very much.
Yes, sir.